Good. All right, here's the information we always provide on CME disclosures, how to receive your CMEs. I have nothing to disclose associated with this presentation. What we're going to talk about today are two relatively big topics that have been really condensed down to sort of like their basic elements. I'm going to talk about the stages of change model and what that is, and also the spirit of MI, which is one of the foundational components of motivational interviewing. And hopefully this will be, for anybody who's not familiar with these two things, a very brief introductory overview to spark your interest and get you excited to want to go and get additional training in how to use these two tools for working with the SUD population, because they're very very important to know, I think, regardless of your role, if you're working clinically with patients with opiate use disorder. So I'm going to talk about core concepts related to the stages of change model, or it's also called the Transtheoretical model of change, and how that applies to being able to use it clinically for assessment and treatment. Also talk about how that model relates to motivational interviewing, and how we can use really the spirit of motivational interviewing, which is sort of the foundational way of being with patients, the perspective that you use when interacting with patients to apply across clinical settings and across clinical roles. So not going to get mired in the actual technical pieces of either of these models, but just giving you the overview of how you can embrace kind of the perspective of them. So why is it important to know about the stages of change model? Well, it is an evidence-based model that really helps us to match the person's place that they're at with what they need to benefit from treatment. And we know there's tons of research that says when we do appropriate matching, when we get people the right type of treatment at the right time in their recovery, the right stage that they're at, it's going to be much, much more effective. This model is not necessarily part of MI. It actually developed separately, but it can be used with MI. So we often see them kind of go together. But I want to be clear, it is a separate model for really assessing the type of intervention that will be most helpful for patients. This is the model in a nutshell. So this shows you that it really is cyclical, and patients don't necessarily move through each one of these stages in a linear way, and so sometimes they can skip things, and they don't always start over from zero. So if someone comes in the door at pre-contemplation and they move through this stage and they do end up having relapse, because you can see relapse is part of the model itself, it doesn't mean that they go all the way back down. So we think of it as sort of an upward spiral or a spiral staircase. The people bring the tools and the knowledge that they've learned along their path, and so they might not necessarily have to restart at pre-contemplation at level 1, that they might go from relapse right back into action. So that's just something to keep in mind. Even though it's set up in this cycle, it really, as people move through it, it's not necessarily linear. So that's what's important to understand each one of these in isolation, so that you know how to best assess where your patient is at. So what are you looking for to determine each one? So let's go through these particular components individually. Pre-contemplation is when a person is not considering change in the foreseeable future at all. And there could be various psychological reasons why they're not considering change, but basically they don't want to change their behavior. They are not ambivalent. They're very clear, I don't want to change this behavior whatsoever. Contemplation is where there actually is some ambivalence showing up. They're considering that change could be happening in the foreseeable future, that there's part of them that doesn't want us to stop or do it differently, but there's part of them that does. That's contemplation. Preparation is when they've moved from that ambivalence to actually starting to plan what they're going to do differently. And then action is where they make meaningful change in the present moment. So it's not just talking about what they're going to do, it's actually implementing what they're going to do. So when somebody's in action, they no longer need things like motivational interviewing, because there's no ambivalence. They're very clear, they want to make this change, they're on board, and they're doing what they need to do that. And then maintenance is just how they sustain action. So the behaviors that have changed and been implemented in action, maintenance is just how they're maintaining that across the various stressors and difficulties and obstacles that show up in their life. So these are the things that sort of the interventions that would be recommended if you've assessed correctly which stage of change the person is in. So when they're in pre-contemplation, like I said, they're really not ambivalent whatsoever. So we can use some motivational interviewing. There's some specific techniques like coming alongside or doing things that really don't require ambivalence that can be used. But by and large, we're not going to use MI during pre-contemplation. We're just going to focus on rapport building, alliance building, and maybe doing a little bit of decisional balance. So asking them to sort of weigh what are the pros and cons of what they're currently doing, just to explore it without judgment. Contemplation is where we're going to use our tool of MI. That's really where MI is meant to be used, is when somebody has ambivalence present. Preparation, we can stop using MI, and MI even says that. It says once somebody gets to planning, they don't need you to work on their motivation anymore. They're ready to actually plan out what they're going to do. And most people, once they're on board with the change, they can plan pretty effectively on their own. They might need a little bit of like skills assistance or helping to look at resources or barriers that could get in the way of their plan, making a reasonable plan, so setting up SMART goals. But by and large, people do planning pretty effectively without a lot of assistance from you. And then action is where you're just helping them move from the plan into sort of a relapse prevention strategy. So saying, okay, you're already doing it. How can you sustain what you're doing? And how can you reflect on what you're doing as a way of building self-efficacy? So looking at how amazing it is that you're making this change. And then maintenance, again, is just really keeping them in that relapse prevention focus. So what are the things like understanding high-risk situation planning, looking at sort of what are their triggers that are really going to cause them to sort of lose sight of what a good work that they've done, what's going to affect that self-efficacy and get in the way and possibly lead to relapse. So in pre-contemplation, the person is just not recognizing that there is a problem that they really need to change. So our goals as clinicians is to just bring awareness of the problem to the surface so they can really start thinking about that. We want to keep them engaged. That's our number one goal. When somebody is pre-contemplative, they're struggling to engage with what's bringing them to treatment. So this might be somebody that's coming in and doesn't necessarily, or they're saying that for a lot of you, they might be wanting treatment for their opiate use disorder, but they're not wanting to look at their marijuana use or their alcohol use or any of the other things that might be on the table. So they could be very much in a contemplation or even an action phase with one use disorder, but they might be in a pre-contemplation phase with another use disorder. And so just you can do this with various conditions with the same person. But regardless, when you've assessed that they are in pre-contemplation for anything that's on the table, our goal is to just listen. So reflect back, use a lot of reflective emotional statements. What are their concerns? What really is causing difficulties in their life? Elicit information, particularly on strengths, because we know the research says that the reason why people don't change or consider change isn't because they don't want to necessarily, it's because they have low confidence in their ability to be successful. And so really helping them to focus on what they've done in the past that they were successful with can build some of that confidence. And then just communicate a non-judgmental, empathic, honest and accepting attitude in all of your work with them. And that can be really difficult because a lot of times when we see people in pre-contemplation, they're really struggling and everyone around them can see that struggle, but they themselves are not quite ready to see that. Or maybe there are very psychological mechanisms in place that are preventing them from seeing that. And so it can be hard for us as providers to sit with that, but that's really our goal when we're working with somebody in pre-contemplation. When someone's in contemplation, this is where they're willing to think about the change, but they're not quite ready to do something about it. And we label that as the ambivalence that's getting in the way. So our goal is to help move them through that ambivalence. Basically, if they're walking on a fence and on one side is change and on the other side is no change, our goal is to walk with them on that fence and encourage them to kind of pick the side of change. So we want to move them toward action, keeping them talking about the change, bolstering their awareness of options, that there are multiple things that they can do, increasing their perception of the benefits of change. One of the ways that we can do that is by developing discrepancy. So really reflecting that the ambivalence is present and how no change is not in alignment with their values and goals. Reflecting that their intention is to be there for their children or to get back to work, or that they have really great intention and we can capitalize on that, give feedback about that. And then address any discord that might be coming up. So as they start to talk more about why they don't want to change, we don't want to get into a headlock or an argument. And that's why MI is such an amazing set of skills to have in this particular phase. One little shift as clinicians that you could try today is if you're talking to people in contemplation and you hear yourself say, yes, but, then shift that to yes, and. That one little change in word can make a big difference in terms of how we're addressing discord. Because when we use the word but, we're now arguing, but when we use the word add, we're just making a suggestion. It's this and it's this. And that can be a really powerful technique that's very, very simple to do. And then the other thing that we're doing is just supporting self-efficacy by helping them to begin to self-monitor their use, review past successes, just sort of affirm the commitment that they've made, even just by coming in to speak with you, even if there's no other change occurring, coming in to speak with you is a commitment to do something or at least look at something different. And then affirming that they do have decision-making ability, they do have autonomy, regardless of how much they're using or how frequently they're using, we can capitalize on that they can make sound, well-informed decisions about their care and their future. Once somebody ends up in action, this is where they're really ready to do something about it. So they're ready to take the steps that they need to take right now, as in today, but they may be, again, lacking some of that confidence. So our goal is to decrease any barriers, encourage progress, look concretely what could be getting in the way, because it could be really specific things that you can help them come up with a plan to overcome. And we want to restrain excessive change so that they actually have experiences of success. So talking about what their plan that they're going to implement is, and then working through that with them, again, very concretely and pragmatically, because sometimes people say, well, I want to stop using everything today. And it's like, that's a great goal, but is that really realistic if they've been using everything for 20 years, right? It's probably not very realistic. So helping them to set up SMART goals that are achievable, and talking with them about, let's take off the bite-sized pieces, right? So that metaphor of how you move a mountain, you move it one stone at a time, right? So helping them to understand that it's about small goals rather than in the service of one big goal, rather than trying to take on one big goal and then failing at that and getting demoralized. A few words about relapse. Understand that it is part of the stages of change model. It is part of the process of recovery. We want to talk to patients about it. Talking about relapse, just like talking about suicidal ideation, does not guarantee people will do it. It does not give them permission to do it, or whatever other thing that we might have been taught in other schools of thought. It is really important to understand it is common, it is part of recovery, it is not a sign of failure. We don't want to think about it as a sign of failure. We don't want to communicate to that patient, to our patients. We want to talk about how it can really very much affect and derail their trajectory if they don't know how to handle it correctly when it shows up. So talking to them about this is a learning opportunity, that if you have a slip, you can actually learn something about what went wrong that led to that could actually sustain your recovery long term. And isn't that great? That's a really beautiful thing to learn from a relapse rather than just kind of trying to like white knuckle and never have that learned experience. So normalizing it and also embedding it in this perspective that substance use disorder is a chronic illness. And we know with almost every chronic illness, there are going to be periods where they do really well with their management and periods where they don't do so well with their management. A lot of that has to do with psychosocial stressors that are occurring in their life, and that's part of life. We can't avoid those types of stressors. So helping them to understand that relapse is probably going to be on the table at some point in time. So let's help them avoid from being discouraged, help them re-engage in the change process. And rather than go back to pre-contemplation where they say, what's the point? I'm always an addict, always going to be an addict, never mind, screw this. We actually help them to get back to action. Okay, something happened, you fell off, let's get back on, right? So that's the stages of change model. Now I'm going to spend just a few minutes and highlight the spirit of MI. This is just a chart that I think highlights why it's so important to know how to use motivational interviewing, regardless of your role. If you work in healthcare, period, regardless of the population you work with, you can see that it's not about resources. It's not about money. So this shows how much money we spend on healthcare versus life expectancy. So obviously we spend way more than almost any other country or industrialized country, but it does not equate to greater life expectancy. So something else is happening in our medical model. And one of the theories hits this statement that was actually written in 1660 that says, people are generally better persuaded by the reasons which they themselves discovered than by those which have come to the mind of others. And so that's really at the heart of motivational interviewing. It's capitalizing on the patient's reasons, their values, what's motivating them, rather than us being the expert and telling them why they should or have to or need to do something different. So it's a very different way of having a conversation or interacting with somebody that is not part of the typical medical model. It is also very effective, and it can be used for talking about change kind of regardless of what we're talking about, whether it's substances or diet or sugar management or medication adherence, any of those changes, you can use motivational interviewing to affect healthy, positive change. It really is a collaborative, person-centered approach, so it feels good as a clinician to use MI. It's not easy, but it feels good once you get practiced with it. And it really does help a person understand how they themselves can benefit and begin to move into that action phase, even with any reluctance or ambivalence that's present. So it's collaborative, it's person-centered. It is not just a collection of techniques. So if you've ever taken an MI training and you know a handful of techniques, that doesn't necessarily mean you're doing MI. It really is a way of being with patients or families. And it is used to encourage behavior change right now. So it can be used no matter what level of use the person is at if they are in contemplation. Remember, if they're in pre-contemplation, we're not necessarily going to be effective with MI, but if they're in contemplation, we definitely can be. And it can be used regardless of the health behaviors. I'm not going to go over this slide. You guys will get this slide, but needless to say, there's tons of research that supports MI as being an effective, evidence-based approach to working with patients regardless of what we're trying to help them make positive changes with. So why I wanted to talk about the spirit is because even with no training, you can begin to think about using the spirit of MI with all of your patients. And really at its heart, it is this one phrase, appreciate ambivalence. So rather than bumping up against it and hitting heads with it, which just means it's a person has two minds, right? They're feeling two ways about something. It's not necessarily a lack of motivation, because motivation is present. Again, it's one side and it's already within the person. But there's another side in there, which is the fear or the concern about the change. So keeping the status quo. And it's a normal part of the change process. All human beings experience ambivalence at any time that they're thinking about or contemplating a change. So any of you that have ever tried to change a habit, you know what this feels like. If you've ever tried to go on a diet or increase your exercise or do better sleep hygiene, at some point you've experienced some ambivalence about that. And so it's just having some respect and appreciation for that within our patients and not getting stuck in what's called the communication trap. And that's where as experts, we really start to argue one side. What's going to happen, and you've probably experienced this if you have children, anytime you tell them what they need to or should do different, what do you get? You get their reasons why they shouldn't, right? So anytime we start to argue one side, they will automatically defend their side. and it's a knee-jerk reaction, and we don't want to fall into that. So using the spirit of MI helps you to get around the communication trap and not fall into it, where they're defending the status quo. Because once it comes out of their mouth, remember that quote, if it comes into their mind, they're much more likely to follow through on it. So if you're having a conversation with someone and they're defending the status quo, they're not likely to change. It is very unlikely that you've actually set them back. You've moved them into pre-contemplation when you're starting to have that kind of a conversation. So what we can do to maintain the spirit is managing what's called the righting reflex. And that's, as providers, we're helping professionals. It is our natural inclination to make something better for another person. So again, we're recognizing they're struggling. We want to make it better. We want to right it. We want to correct the course. And that's a natural instinct that we have that's hardwired in us, probably personality before we even got into this profession, but definitely now that we're in this profession. The danger is, though, that as we tell other people what to do, how to do it, why they should do it, without using the spirit of MI, without using that different way of talking to them about it, it's just going to create resistance, and we're going to end up in that communication trap. And so some of the reasons why this happens is, we believe we have some misinformation or some biases as health professionals, that we believe they just don't see the problem. They don't know what the problem really is. They don't know how to do anything about it, or they just plain don't care, right? They're just so hardened or have such learned helplessness that they just don't care. So what we think our job is to give them insight, to give them knowledge, and to give them skills. And that all seems very reasonable. Unfortunately, when someone has ambivalence on the table, that's not what they need. They need this in the action phase. They need this in the maintenance phase oftentimes, but they don't need it when they're contemplative. When they're contemplative, what's happening is our righting reflex is butting right up against their ambivalence. So we're in this like headlock, and I'm sure all of you have had these conversations and you feel it. You feel that shift in the room where you're now arguing, even when it's really civil. So what happens for patients, we can have a couple different outcomes when we've engaged in that righting reflex, is they might make the change briefly if they're good patients and they want to make us happy, right? But it's not coming from them, so it's not sustained. They might listen politely and just nod and say, oh yeah, sure doc, I'll do it. They have no intention of doing it, right? They're just going to continue to do what they're doing. They might actually argue with us, protest and push harder. So we might experience that argument. But at the end of the day, nobody benefits. We're not helping and doing what we're intending to do, and they're not getting better. What we also fall into is blaming the patient and saying, so if you've ever said, they're just not motivated, they're just not ready, right? I need to wait for them to be ready. It could be that we weren't really using the spirit of MI when we were working with them. It could be that they truly were in pre-contemplation, but as I just said, if you've assessed them correctly and they're in pre-contemplation, there's still a lot of things we can do. We're not going to do MI necessarily, but we can build that relationship. We can engage them. We can listen without judgment. But if we're ever saying they're just not motivated, I'm going to wait till they're motivated to have any contact with them or work with them, then we might be missing a really big piece of the puzzle here. So understanding the rule as part of MI is resist the righting reflex. Always, always, always. Understand their motivations. So work really hard to understand clearly why they would want to change. Listen to them. If you're talking more than they are, then you might not be doing this correctly. And then empower them. So remember that people change when they feel they have the skills and the ability to do it. They tend to lack confidence. So it's not that they don't want it, it's that they feel they're not going to be successful. So approach it from that perspective. How can I help you be successful? What does that look like, right? And my version of success might be different than their version. So I might have to adjust that so that it truly is in alignment, again, with their motivations, their values, and their skill set. So you can see the spirit of MI is foundational to any MI. So if you go on to do additional training, you'll learn the principles, you'll learn the processes, you'll learn the techniques. But if you don't have the spirit and you're using that way of being with someone, resisting the righting reflex, understanding their motivations, listening and empowering them, you're not using that rule, then your techniques are not going to be as useful, right? So here's a couple concrete things to keep in mind when really trying to embrace and use the spirit in all of your interactions with your pre-contemplative patients. Number one is acceptance. Number two is collaboration. And number three is evocation. So let's go through what that means. With acceptance, what we're talking about is accepting the person in front of you as having absolute worth. So really approaching them with a positive regard and an absence of judgment. This is going to foster respect and trust between you and the patient. When people feel that they're being accepted, then they're free to change. It's this miraculous thing. So when you sit with someone and you're of the mindset, you need to change, you need to change, you need to change, they're going to defend the status quo and tell you all the reasons why they don't need to change. That's just a natural response. But if you're sitting with someone and you're saying, I accept you completely for who you are right now. I'm accepting your struggles. I'm accepting your frustrations. I'm accepting the limitations that you're bringing to the table without judgment. Then they're like, oh, I can actually think through, maybe I do want to change. So it's this really counterintuitive approach as healthcare providers where we just accept exactly who they are, where they are. And we really try to use what's called accurate empathy. And that's where we use our good listening skills to try to understand what's going on with them internally. What is their internal perspective, the meaning and values that they embrace as part of their orientation to the world. And then this supports what's called autonomy support. So that's just acknowledging no matter where they are at any point in time, they have the freedom to make choices about their life. Even if we don't agree with those choices, even if those choices harm them, they have the freedom to make those choices. So we need to have the kind of attitude and behavior that really are always supporting that. Yeah, you can absolutely do that. That is completely your choice. Would it be okay if we had a conversation about what that might look like? Let's just take that down the road a little bit and look at that. Right, that's a really helpful conversation to have with somebody. We're not judging it. We're not telling them they have to change. We're just exploring it with them. And then we can probe for more of that accurate empathy and be able to affirm their strengths and their efforts. That's really important too. Regardless of what they're able to change and put into place, it's the intention that matters. And we can always affirm that. We can always say, hey, you showed up today. That's phenomenal. I'm going to affirm that. The other piece of this is acceptance, which is, again, affirming their right and their capacity for self-direction and to make an informed choice, honoring them regardless of their use behavior. That's very different than the typical medical model, which is coming from, I'm going to tell you what you should or you need to do, and assuming that you need to be told or instructed on that. So now let's talk about collaboration. With collaboration, this is where I'm not seeing myself as a one-up, right? That we're kind of on an even playing field. I'm recognizing I have expertise and knowledge I'm bringing to this conversation, and you have expertise and knowledge about your life, your values, your previous experiences of success you're bringing to the table. I can't know that about you, right? So we're both experts in this conversation, and we're going to collaborate together. So the best metaphor for thinking about using the spirit of MI with collaboration is dancing with somebody rather than wrestling with them. It's not about dominating them or forcing them to do something different or coercing them or persuading them, but it's about just dancing. So I'm going to guide in this direction, and they might guide me in another direction. Well, I need to go with them in that direction, or we're going to disconnect, and we're not going to have that collaborative spirit anymore. So it's about exploring more than persuading. And when we do that, it's actually easier on us. They tend to, when we create that stage, they will bring up all the reasons why they want to change. We don't have to bring it up. It's pretty amazing. They will do it completely on their own. So if you think about collaboration, it's really done for them and with them rather than against them. So we're recognizing they are the experts on themselves. So we develop that partnership versus the traditional medical model, which would be a little more confrontational. So requiring them to do certain things, like I'm not going to give you X if you don't do X. And of course, there are certain limitations to that in terms of maintaining safety, but other than safety as the number one, helping to be more collaborative with trying to understand where they're coming from, why they're doing that, the purpose that it's playing in their life. That can be very much a part of embracing the spirit of MI. And then lastly is evocation. So what does that mean? That means that we understand and completely acknowledge that they have what they need already, that they don't need any more skills or tools to change, right? Or at least to want to change, to get on the other side of that fence. All our job is to help evoke it, right? Is to help bring it forth. So what we're acknowledging is the motivation and the resources are already there. We don't have to wait for them to quote unquote be ready. It's not something that they like stumble upon one day. It's already there. We just want to evoke it. We just want to bring it forward. And how we can do that is by continually talking to them about their why. Why do you want to do this? And understanding truly their perspective and the wisdom in that perspective, because they have wisdom that's part of that change. So when we're using good evocation, what we're doing is enhancing that intrinsic motivation by talking through their perceptions, their goals, and their values. And that's different than the perspective of we need to provide them education, which is saying that they lack that knowledge. So that's where we're trying to give them handouts and resources and statistics. And did you know that you could die from blah, 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 right? That's education. That has a place. I'm not saying we don't do that, but when somebody is in contemplation, that's not going to be helpful because we're going to get into that headlock. So what we want to do is be focusing more on how do I evoke that wisdom, that motivation that's already there. They already have it. I don't need to give it to them. I just need to try to bring it forward. So in a nutshell, if you're really using the spirit of MI, which I think all of us, regardless of our role, can do this, but it takes work, is to just shift in your head from this wrestling mindset. I need to get them to do it different. I need to explain it to them or teach them or help them to just see the light. That's different than dancing, which really is the spirit of MI, which is embracing the fact that they're coming to the table with a whole host of things that we can capitalize with. They can be a really good dance partner with us if we're willing to have this, this collaboration. So that's all I got. I don't know if people have questions about stage